Hello, everyone. I'm Sheldon Baker, the host of Healthy Bytes. My guest today is Dr. John Neustadt, who is a naturopathic doctor and the founder and president of the dietary supplement company Nutritional Biochemistry and NBI Pharmaceuticals. Dr. Neustadt founded NBI in 2006 after he couldn't find products that contain the amounts of nutrients shown in clinical trials that he needed for his patients. He received multiple U.S. FDA orphan drug designations for the potential treatment of rare diseases using natural products. Dr. Neustadt hosts the Delivering Health podcast, is a member of the Bone Health and Osteoporosis Foundation's Corporate Advisory Roundtable, has published 5 books and more than 100 research reviews. The world's largest medical publisher, Elsevier, recognized Dr. Neustadt as a top 10 cited author in the world for his work. And Dr. Neustadt's latest book is Fracture Proof Your Bones, expanded and updated edition. Dr. Neustadt, great having you here today on Healthy Bytes.
Thank you. It's great to be here.
You've mentioned that even as research has advanced, many doctors remain unprepared to answer basic questions on bone health. What specific knowledge gaps in the medical community made your second edition a clinical necessity?
Well, there have been multiple studies that have been published on this showing that doctors are often confused when it comes to interpreting the bone density test results. They're uncertain as to the potential benefits and risks of the different osteoporosis medications and when they even might be indicated or when a better one might be the best choice. They are not comfortable having the more nuanced and in-depth conversations around diet, lifestyle, exercise, or supplementation and answering questions about dietary supplements beyond possibly calcium and vitamin D. And the amount of time that doctors have available to them to spend with patients in short office visits makes those more in-depth conversations really not possible within that time frame. And so there was a need clinically, based on my 2 decades of work in this field, to help clinicians understand how they can create holistic bone health programs for their patients. And yes, medications might be part of that, but it's part of a larger discussion, and help patients and doctors to navigate that and ask the right questions to get better outcomes.
So in your book's preface, you state that many clinicians are still fixated on bone density rather than the goal of reducing fracture risk. So how does your book teach providers to shift their testing protocols to focus on structural bone quality and patient independence?
It's a paradigm shift. All of us were taught in school to focus on that number on the test and to try and improve the test results. It feels good to do that, and there is some value in that, but it is more limited than most doctors understand, and definitely than most patients understand. We've known for decades, or it's been in the research for decades, that a bone density test result only predicts 44% of women with osteoporosis who will fracture, and only 21% of men. It's just one piece of a much larger puzzle. And in fact, medical articles have come out showing that even the improvement in bone density that osteoporosis medications create is not an indicator that they are reducing fracture risk. The bone density test gives a number, but the most important thing when it comes to people's health is not the number on a test. It's whether or not they break a bone. If you're a woman with osteoporosis and you fracture a hip, there's up to a 36% chance that you're going to die within a year. And if you're a woman with breast cancer and you end up in the hospital with a fracture, there's an 82% increased risk of dying compared to a woman with breast cancer who doesn't fracture. And for men with osteoporosis, a bone density test alone only predicts about 21% of them who will fracture. And so it's about asking different questions and reframing this condition, not around surrogate markers, but about what we can do and what the research shows we can do and what patients can do to reduce their fracture risk.
So how do you get doctors to make a change in in essence, their diagnosis?
I think that the challenge is not that they are resistant to making a change. And the diagnosis is what it is. I'm not asking people to change the diagnosis because the diagnostic criteria for osteoporosis are clearly defined. And that's okay. It can be diagnosed based on the bone density test or another test. It can be also diagnosed clinically in some cases. That to me is not the most important issue. The most important issue around diagnosing patients is that most patients aren't even getting screened for this condition. 95% approximately of Medicare eligible patients are not getting screened with a bone density test. And as your listeners know, that's patient population 65 years and older, and they're at the highest risk demographic for this condition and for fractures. And so getting people screened, getting the diagnosis is really important. And then the question is, once that diagnosis is there, once there's a problem, what do you do about it? How do you work with patients? And I think that doctors, every doctor that I talk to, when I share with them the data and the research and my book, and they go perhaps listen to one of my continuing education talks, it's not that they don't want to change. These are very well-intentioned, incredibly well-meaning and well-educated professionals. They just haven't been taught this before, or how to implement it in their clinical practices in a way that can just seamlessly become part of their routine instead of disrupting what they're already doing.
So with new book chapters on medication-induced bone loss and FDA-approved drugs, how does your research help clinicians ensure that pharmacological interventions actually lead to fewer fractures rather than just better numbers on a DXA scale?
The important thing to look at are the clinical trial outcomes and the meta-analyses that have been done on these medications, because when you start digging into the research on the medications, most of the clinical trials were done for secondary fracture prevention. That is, patients who have already had a primary or a first fracture. And the fracture reduction of these medications is different in terms of their potential benefits, whether it's a primary fracture or a secondary fracture prevention that we're trying to work with. And so I outline the data with citations of what the research shows in terms of primary fracture prevention. For example, the most medications for osteoporosis do not prevent primary vertebral and hip fractures. They're better at primary vertebral fracture prevention, but most of them do not prevent a primary hip fracture, which is the most dangerous type of fracture. Although there is one that does, intravenous Zometa. So it's about helping them choose the best medication for the outcome they're trying to create. And that outcome, in my opinion, should be centered completely on reducing fractures. For me, every question around this condition starts and ends with fractures.
Addressing the underserved specifically, you were talking about the David case study. You dedicated this book to those who felt dismissed, and you highlight the specific case of David. Why is the medical community currently failing to identify and treat bone loss in men, and how does this edition rectify that oversight?
Well, I think one of the challenges for men and for many other populations that are out there that are struggling with bone loss or at risk of osteoporosis or are breaking a bone without having ever been screened is that 80% of cases are in postmenopausal women with osteoporosis. And so that's where the majority of the research dollars and research efforts have gone into looking at postmenopausal women with osteoporosis. In the case of David that I talk about in my book, he had bone loss that was detected, and they didn't test his testosterone. But even I see a lot when testosterone is tested, they don't test estradiol as well. And it's estradiol in men that is crucially important for building and maintaining bone density and bone strength. And so it's just part of a gap in the education around this condition. There is no board certification for osteoporosis. There is no osteoporosis specialty. It is primarily the purview of the primary care physician to screen patients, to get them screened. And yes, they may then refer to an endocrinologist, but even an endocrinologist, there's no board certification in osteoporosis, or definitely no training around this comprehensive, holistic approach that the research supports and shows can provide superior patient outcomes.
I understand many readers brought your first edition into their doctor's appointments to fact check your recommendations. How does the second edition take action sections facilitate a more collaborative, less fear-based relationship between patients and their healthcare teams?
You know, when I first heard that patients were taking the book into their doctors, it was a pleasant surprise for me. I was thrilled. Because oftentimes what happens is that the doctor, based on the protocols that they've been taught, they're wanting the patient to take a medication, and they're not comfortable pursuing other avenues, or they don't feel that it's necessarily safe to do so. And so when the patient reads the book and they come in with the book with all the hundreds and hundreds of citations that are in there, and they show that to their clinician and they talk about the program that they're creating, because the book walks people through chapter by chapter how to create holistic bone health programs for themselves, or teaches clinicians as well how to do that with their patients. I've heard story after story that the doctor has said to the patient, okay, let's give this a shot. They feel more comfortable trying something else. Let's give this a year. Let's follow this, and then we're going to retest and we're going to see how it goes. And so there's still this collaboration between the patient and the doctor. The doctor feels like they're involved, as they should be, and the patient feels heard and that they're able to make more informed decisions. In addition to that, I've even heard from doctors that they're prescribing the book. They will say, this is what we're going to do. Read the book, and we're going to implement this program.
You've said that your second edition will help readers create a customized bone health program that makes sense for them. How will your book guide clinicians and patients through the complex variables of gut health, medication history, and specific exercise risks to move beyond a generic, more calcium approach?
That's a great question. This is a complicated picture. Like all chronic diseases, there are many variables involved in this. So part of it for me is prioritizing, where do we focus? What are the most important things to focus on? Osteoporosis essentially is a condition of imbalance where the destructive forces are winning. And so my first and one of the highest priorities is, can we identify what is damaging bone and reduce that impact or eliminate it entirely? So medication review is crucially important because there is a long list of drugs now that we know damage bone, cause osteoporosis, increase the risk for falls, and increase the risk for fractures. And most doctors are unaware of that. A study came out years ago that looked at what medications patients were taking in the 3 months prior to ending up in the hospital with a hip fracture. And what they found out was about 75% of those patients were on a medication that damaged bone, caused osteoporosis, and increased fracture risk. When they left the hospital, there was no net benefit, meaning if they were taken off one of those medications, they were just put on a different one that the doctor unknowingly put them on without the understanding that it also damaged bone and increased osteoporosis risk. And some of the most common medications do that. Antidepressants, for example, anything that artificially increases serotonin. Research now shows people on SSRIs, women on SSRIs for 1 to 5 years, for every 19 of those patients, we'd expect 1 to break a bone. So that's just one example of identifying risks and then trying to deal with that either through a holistic approach, maybe changing to a safer medication, or maybe through functional or naturopathic medicine, through testing, nutritional approaches. Maybe we can get them so they don't need the medication at all. With respect to gut health, there is a gut-bone connection that is indisputable now. Chronic inflammation of the gut directly and indirectly damages bones. And so in the book, I go through that. I go through the secondary causes of osteoporosis and bone loss caused by chronic inflammation, irritable bowel disease, other gastrointestinal, autoimmune diseases, and other conditions that do that. So people can start to conceptualize if this is going on in my patient, if they have irritable bowel disease, then what do I need? What should I test for? What should I look out for in terms of nutritional deficiencies? How can this be approached to try and heal that gut, so that we can also at the same time work on the bone health, improving the bone health through these integrative strategies of diet, lifestyle, nutritional supplements, when appropriate. And through that lens, it helps doctors and patients really cut through a lot of the noise that's out there so that they can, with a very clear understanding, prioritize first, second, and third steps on how to monitor things and how to track over time.
Dr. Neustadt, thank you for joining me on Healthy Bytes and sharing information about bone health.
Thank you. I appreciate it.
And thanks to all of you for watching Healthy Bytes.